to be talking about our
Conference record has joined the conference.
That includes you, Ken.
Beautiful. Beautiful.
And I'll introduce the whole thing about the concept of the PCORI initiative and how this.
Excellent. Excellent. Well, for those of you just joining, this is Dr. Ken Duckworth, Medical Director of the National Alliance on Mental Illness. My guest today is Dr. Andy Nierenberg, the Director of the Bipolar Disorder Clinic from the Mass General Hospital. We're just waiting for a few more people to join. While we're waiting for people to join the call, I want to remind you these calls are recorded. So if you ask questions about yourself or someone in your family, just be mindful of that. They live on the NAMI website. All of our expert talks at www.nami.org/askthedoctor. I'm just going to wait a few more minutes before we begin. And is anybody on the call willing to introduce themselves and say hello to Dr. Nierenberg so you can get a sense of who he's chatting with today, please?
I'm Christy Lupoli, and I am calling from Santa Barbara, California.
Probably a little warmer there than it is in Boston, isn't it? We're running in the single digits today.
No, it's downright. It's foggy but balmy. You would call it balmy.
And hello, my name is Pete Lupoli. I'm also in Santa Barbara with Christy.
Great.
Good morning.
Good morning.
I'm Becky Blend. I'm from Helena, Montana.
Good morning.
I'm Susan Johnson. I'm from Great Falls, Montana. Susan Johnson.
My name is Lois. I'm in Arizona.
West Coast heavy today, Dr. Nierenberg.
How do you like that?
I like it a lot, actually. NAMI covers a lot of bases.
I know. Well, people on the East Coast are just trying to keep warm.
well many Julie. People... Oh, sorry. Go ahead. Sorry.
I was just going to say, I'm Julie, and I'm on the East Coast, and yes, staying warm is a challenge right now.
Julie, where are you from?
I'm from Connecticut, and had the pleasure of hearing you speak, Dr. Duckworth, at the Canton Library a couple months ago.
Oh, crap. You're so sweet, and you've decided to come back for more, so you're
yes. Yeah, I really would love to hear you speak on a weekly basis.
We're just introducing ourselves, any of you who would like to. We have Dr. Andy Nierenberg, who's going to be starting the conference in a few moments. I just was asking folks to introduce themselves if they were willing to do so our good doctor would know kind of who he was chatting with the audience, get a sense of it. The dog brings up an excellent point. *6 mutes your calls, and #6 unmutes them. So if you have to do side conversations or work or have a barking dog, just hit #6 and you can listen to our call. If you want to ask a question after Dr. Nierenberg's introductory remarks, just hit #6 and we'll be glad to take your call. So without further ado, I'd like to say thank you to Dr. Nierenberg, who's really been a national leader in helping people with bipolar disorder maximize their recovery. And he's done this from looking at a lot of different perspectives on bipolar disorder, from the medications to the lifestyle, stress management, also having people really track their own symptoms, report on them, and he's probably doing things that I'm not aware of because he's that much of a curious person. So let me just introduce and thank Dr. Nierenberg. I'll have you take it away, and then perhaps 15 or 20 minutes so later we'll have people unmute their calls and jump in for a unstructured but very NAMI-like free-for-all of questions and answers. So take it away.
Well, thanks, Ken. Thanks so much for inviting me here today. I have the very, very edge of a cold, so excuse me in advance if I give a little cough now and then. There are really two main things that I wanted to discuss with the people on the call. One is actually a collaboration that I'm doing with Ken and some other people with NAMI and with the Depression Bipolar Support Alliance and the International Bipolar Foundation, as well as the Anxiety Depression Association of America. There is really just an extraordinary thing that's happening, which I will tell you about in a moment. And then I'm going to tie that into the whole notion of wellness in bipolar disorder, getting to well and maintaining it, and give you a little bit of background on that. and some of the things we're trying to do to help people get to and maintain wellness. So the first is the collaboration that we're having with NAMI and with Ken. And this is an absolutely brand new, hot off the press, just back from a 3-day meeting in Washington on this. And this has to do with the Patient-Centered Outcomes Research Institute. The Patient-Centered Outcomes Research Institute, also known as PCORI, and they have put together a network of networks with the incredible ambition to change the entire healthcare process through collaboration with really patients and their families, with researchers, with clinicians, with insurance companies, and they are making a $100 million investment in something they call PCORNet, or Patient-Centered Outcome Research Network. And what this is a network of networks where people will be invited to join the networks as true collaborators across multiple disorders and across multiple things that we all have because we're all patients in some way or another. The thing that's really exciting is that Ken helped us in collaboration to get the only network out of 29 networks. We got the only one in psychiatric disorders. And we have what's called the Mood Patient-Powered Research Network. And the Mood Patient-Powered Research Network, or Mood PPRN as it's called in PCORI speak, has an extraordinary aspiration. And the aspiration is within 18 months to collaborate with no less than 50,000 people across the country who have a mood disorder, whether it's depression or bipolar disorder, and who are willing to collaborate to do several things. One is to provide their longitudinal electronic medical record data, which in these days of data security sounds a little scary and daunting, and I think we're going to have to do a lot of work to convince people about the security of those data. And the second thing is to get patient-reported outcomes. And what Ken and I and other people are building over the next 6 months is a patient-centered type of endeavor to figure out what data would be helpful for people to know. And this is not only people who have the disorders and their family, but also their clinicians and also the researchers who want to try to work with everybody to see if we can get better answers and better outcomes. As many of you know, the outcomes for many people with bipolar disorder are less than optimal. And the research over the past, decade or so is that even with the best treatments that we have available, we're probably lucky if 30% of people get fully recovered and then maintain that recovery for at least 2 years. Most other people struggle with a waxing and waning course, and we really want to change that. So the Mood Patient-Powered Research Network is meant to change the entire game by gathering up, again, 50,000 people who will change the way that clinical research is done, who might be available for subsequent studies in the future to compare competing treatments, to compare ways of doing things. And essentially, we would invite people to join us as members and citizen scientists, as true patient collaborators, not as subjects, not as research participants, but as true collaborators who have a voice in this whole endeavor to really change the way things are done. So we're really excited about doing this, and we have 18 months to build this, to bring people together, and then we'll see what happens after that. But one of the most exciting things about the Mood PPRN, the Mood Patient-Powered Research Network, is that the questions that we ask will come from our patient collaborators, citizen scientists, and it's in collaboration with them that we'll not only ask the questions that are most important to everybody, but we will also prioritize it. So there's more to come. If you want to look up PCORNet, that's PCORNET, you can learn more about the entire thing. We are, as quickly as we can, trying to build our website for the Mood Patient-Powered Research Network, but it's an incredibly exciting sort of thing that we're doing. So in that context, what is the purpose of the Mood PPRN? What is the purpose of treatment? What is one of the central struggles that people have if they have bipolar disorder? And I would contend, and I'll love to hear from all of you online when we open up the lines, that the biggest challenge is getting to well. And that brings up a lot of interesting questions and interesting challenges. So the first challenge is, what does it mean to be well? What does wellness mean? What does that comprise? And what are the different facets about wellness that are important? And what is it that you can do for those of you who live with the disorder? And what is it that your clinicians can do who are trying to help you live with it? So first, the definition. And I'll give you what it's not. Wellness is not just the absence of illness. And so the absence of illness is not the presence of wellness. The fact that you're not feeling pain doesn't mean that you want to do things. So there's a whole area that has been studied about wellness and psychological well-being. And I've been very influenced by the work of Carol Riff, R-Y-F-F, from Wisconsin, who has spent her entire career trying to study psychological well-being. So I'll tell you a little bit about her work and how that informs what we're trying to do here, and I think it'll resonate with you, because she has a great definition of psychological well-being and has 6 different aspects of well-being that I think I'd love to hear your thoughts about it. So she defines well-being as having self-acceptance, having environmental mastery, having positive relations with other people, having a purpose in life, a continuous sense of personal growth, and autonomy. Let me just say that once again. Right? So there are 6 different aspects of psychological well-being. There is self-acceptance, environmental mastery, positive relations, a purpose in life, personal growth, and autonomy. And she has many different aspects of each of these that go into some detail, and she even has a way to measure these things. She has a psychological well-being scale. And if you think about it for a moment, if you have the absence of any of these things, self-acceptance, environmental mastery, you have some sense of being able to control your environment, positive relations with other people that are mutually beneficial, that you both feel that you're better off for having that relationship than if you didn't, a purpose in life, why are you here, what are you doing here, what is your purpose, a sense of personal growth, that you're always learning, you're always growing in some way for the better, and some sense of autonomy, that you have a say in really what happens to you. If you imagine what it's like not to have any of those things, you could understand that it's not just illness, but those things need to be there and that's part of psychological well-being. The other aspect of psychological well-being is a sense of resilience, and that is that life is full of slings and arrows, and we all face at some point different stressors that can happen. We all experience some loss of either something or somebody that was important to us. We all face disappointments in life. The difficult job that we have, the difficult task that we have, is to be able to bounce back from that and to have resilience. So it's yet another aspect of wellness. The other thing that's quite remarkable about the work of Carol Riff is that her work was mostly ignored for about 20 years. And then she actually found that there was a relationship between psychological well-being and mortality. And here's the way it went. The lower your psychological well-being, the earlier you died. And that is on a population level, not disease-specific, not disorder-specific, not psychiatrically specific. But she found that there was a relationship between markers of cardiovascular risk, of markers of inflammation, of things having to do with sleep, which of course in bipolar disorder is really a big problem. And she found that the better your psychological well-being, the better these biological markers were, and the more on average you actually lived. So the other very important aspect of wellness has to do with physical well-being. And my good colleague, Louisa Silvia, is funded by NIMH to look at a whole project, a whole way of being in terms of really, in a sense, living well. And that's through exercise, nutrition, and sleep. And she has a very nice project where she's looking how to get people to actually do that and sustain that. In many ways, what we're really talking about are both psychological ways of being, ways of having well-being, and physical ways of having well-being that all help dealing with stress. And my other colleague, Thilo Deckersbach, again, his first name is Thilo, his last name is Deckerbach, is also looking at mindfulness and whether that can help people who have bipolar disorder by helping them be more resilient, by helping them be less reactive to their own internal dialogue, and to be able to have mindfulness, stress reduction, mindfulness-based cognitive therapy, and whether that helps both with sleep and with the way that we all react to that constant river of thoughts and images in our thoughts throughout the day. So one of the really big challenges that we all have is being able to regulate our responses. And that's one of the big challenges for people who live with bipolar disorder. So dysregulation can happen in multiple ways, and it's one of the things that people have to master. So it's not just the classic, are you manic or hypomanic, or are you depressed? First of all, one of the things that we've learned from a recent project that we did is that almost everybody has some mixture of manic and depressive symptoms. So people who are depressed have manic symptoms, people who are manic have depressive symptoms, and so it's not so simple. The other thing is that makes it very challenging is that a lot of people with bipolar disorder have anxiety symptoms or even anxiety disorders that are frequently not really attended to well enough. Other people have fallen into smoking as a way to regulate their attention, in part because that's another aspect of what happens with cognition, and sometimes they find that the smoking helps that, but it also causes other problems. And of course, people struggle with substance abuse that can also go along with bipolar disorder, both alcohol and other substances, which can really complicate everything. One of the things I mentioned earlier was the aspect of sleep, and sleep hygiene and people having dysregulated sleep and struggling with either sleeping too much, partially because of perhaps their depression, partially as a side effect that can occur with some of the medications, but also a lot of people have difficulty with having a regular sleep schedule and being able to wake up at about the same time, go to sleep at about the same time. And if you really wanted to make someone manic, you just make them sleep deprived for any extensive period of time. So it's another facet that really needs to be looked at. So I'll just summarize what I've talked about and then really look forward to the conversation. The one thing is this extraordinarily exciting thing that we're able to do together in collaboration with Ken Duckworth and NAMI and Depression Bipolar Support Alliance, among others, for this Mood Patient-Powered Research Network. And so you'll hear more about that over time. We'll really advertise for that, make it worth people's while to consider collaborating with us on that. And then the next thing I talked about are these different aspects of wellness, some of which you may not have heard before, and I hope that it resonates with you. So with that, let me end, and again, looking forward to the conversation.
Thanks, Andy. That was a really nice summary, and there's a lot of interesting areas that we can all work together on. So questions for Dr. Andy Nierenberg. Take it away.
May I begin? My name is Peter.
Sure, Peter, go ahead.
Thank you. I appreciate your summary, Doctor. It was very lucid. And Christian, my son, suffers from manic depressive. And while your categories are all quite clear to me, what seems to be underscoring all of these 6 outlines that you've indicated is self-doubt and uncertainty. Before he's 23, but before the events occurred several years ago, he was a person of a blooming and unlimited ability and assuredness, and this self-doubt and uncertainty in his ability seems to have undermined all of the 6 categories that you talk about. So do you find that as a major category as well, this questioning one's place, what's happened, can I ever do this again, do I have a future? Is that an undercurrent in all manic depressives?
So thank you very much for that comment and question. One of the great challenges for young people who experience this is that there are 2 things that happen, among others. But the 2 things I want to emphasize is, one is it stops people's development. It gives you a roadblock to developing into who you're going to be. And the other thing is that it's so disruptive that it can make you question yourself about what you're able to do or not able to do, and that, in a sense, people can lose their vision of the future. And one of my colleagues taught me this really amazing phrase, which is that to function, we all need to have a memory of the future. We need to remember what it is we're striving for, and we need to remember what our goals are, and that has a very powerful effect on our decisions and what we do day to day. So if somebody gets struck with a disorder they didn't ask for, and it disrupts their development and trajectory, then that will lead to self-doubt and uncertainty. What happens now? What is it that I can do? What is it that is possible? What have I lost, and now how do I adapt to that? And these are extraordinarily difficult challenges that I think take a lot of work and support.
Well, I appreciate your clarity on that, and it is exceptionally disruptive. So what do you suggest to revitalize that spirit of your memory of the future, and that there is a bright light at the end of the tunnel, and it's not a train coming at you, but it's a bright star that is your future. So what do you suggest in that regard to reinstill the feelings of hope and continued well-being?
So I think to really work closely with all the supports, both in terms of psychotherapy, in terms of the medications that can help as much as possible, in terms of, in a sense, as I said earlier, living well, exercise, sleep, nutrition, relationships with people, and to be persistent in hopefulness, and to be able to realize that things can wax and wane, and sometimes they're more difficult than not. But one of the things about also mindfulness is that it can help you realize that if things are bad, that tends to pass. And in a sense, things can pass if they're very difficult and painful. And if one has to accept one's lot in life, then you have to see what you can do with what you have.
Well, I thank you for that. I want to give someone else a chance to speak, but I would add to your mantra, memory of the future, the other one, which is all things good and bad pass.
Yes.
Nothing is permanent. Thank you so
it's
much.
It's a profound truth that we all have to face.
Unfortunately, yes.
Another question.
I have a question.
Go ahead.
This is Lois out here in Arizona. I don't remember all the initials that you used. The PCORNet or something?
Yeah. It's a patient-centered outcome research network, PCORNet, and we're going to have the Mood Patient-Powered Research Network.
Okay, my question is, you haven't really addressed, I have a daughter who has bipolar disorder. She also has psychosis, and while she's doing much better now, for many years she didn't have insight. And she was, involuntarily treated, which was really a godsend. But you didn't address any of that, and I'm wondering if on any of these programs, like I'm a legal guardian, would I be able to go on there and, put things in for her as her guardian?
We don't know yet. It's one of the questions that collectively we're going to have to do. And I say that in the context of
that population doesn't matter if we're not allowed to do that, is my point.
Yeah, this is the in my almost 30 years of being in the business, this is the first time that we're putting something together from the get-go, from the very beginning, with patient collaborators, citizen scientists. And we have people at the table who are patients, family members, who also the advocacy groups that will help us make these decisions together. But I think that your point is extremely important, that I can bring to the larger group to see how do we do this, because there are interesting ethical and other legal problems that we would have to overcome, but I think we'd have to do it in order to be able to help people like your daughter.
Well, right, because I've heard something like half of people with these really serious mental illnesses don't have insight to be able to participate themselves.
Right. No, it's a very important point, Lois.
This is Ken. A couple things about that is I'm impressed that with bipolar disorder, this is often episodic unawareness that is inconsistent and is, often interrupted by periods of, great awareness or partial awareness. So on the Friday Call series, just as an aside, we take up this issue. One of my regular speakers is Javier Amador, AMADOR, and I've also had discussions about involuntary outpatient commitment on the call. So, this is a real issue. The lack of awareness of illness is a complicating dimension to the serious psychiatric disorders for some people some of the time, and some people all the time. And this represents, another tremendous challenge that we have. So I think Dr. Nierenberg's right. We have to, think about that in the context of trying to figure out how to help people when they do have awareness and to think about when they don't. Another question for Dr. Nierenberg.
This is Janice from the Chicagoland area, and
Go
I
ahead.
know you hit on a topic about anxiety, how bipolar patients, generally having anxiety, and it's really not being treated as well. And I just wanted to find out a little further because my son does suffer from anxiety, and the doctor is a little leery to treat it, afraid that it could produce manic because it's an antidepressant that treats anxiety too, but it could bring on mania symptoms.
So, Janice, thank you for that question. The treatment of anxiety in bipolar disorder is remarkably understudied, and to my knowledge, there are no more than 5 studies that have looked at any intervention for anxiety and bipolar disorder. And the most recent studies have looked at the second and third generation antipsychotics that help people with anxiety. The use of things like the benzodiazepines and Ativan or Klonopin for anxiety have not really been studied well enough. Some savvy clinicians will use other things like gabapentin or things that are really off-label to treat anxiety. The whole issue of the antidepressants is extraordinarily complicated, and my good colleague Terry Ketter has estimated that maybe 1 out of 7 people would really benefit from antidepressants, even in terms of anxiety. And other people, it may do just what you said you're afraid of, that maybe it would kick someone into mania. So it's a tremendously understudied area and really important.
Dr. Nierenberg, could you take a second and go over the STEP BD, the largest NIMH-funded study of bipolar disorder? Talk a little bit about what we learned about antidepressants and bipolar depression, because I think that's a point that a lot of people don't know. If we could just take a second on that.
So the STEP BD was the systematic treatment enhancement program for bipolar disorder that included about 4,000 people who were willing to be treated and followed for up to 2 years. And within that group, we did a study that looked at whether or not adding an antidepressant or adding placebo would help people with bipolar depression. And what we found remarkably, if anything, was that the people who took placebo did slightly better than the people who took an antidepressant. And the antidepressants that were studied were paroxetine, Paxil, or bupropion, Wellbutrin. Now, so that study showed that placebo was a little better on average than those 2 antidepressants if they were added to an ongoing mood stabilizer like lithium or valproate or one of the atypical antipsychotics. But the other data on whether or not the antidepressants help or harm is extraordinarily mixed, and on balance show that on average the antidepressants don't seem to help that much. But there are individuals who seem to benefit from it, and that's why it's so cloudy and difficult.
Thank you. I just wanted to make sure, we discussed that point, because that was a key finding from this large research study that I still think I've been impressed that a lot of primary care doctors don't seem to know that, for instance. So it's an area of ongoing education.
Well, if anything, still, this study was published 7 years ago in the New England Journal of Medicine, and the most common medication that people take if they have bipolar disorder or that they're given are still antidepressants.
Right.
Yes, I have a.
Go ahead.
Oh yeah, that touches on a real up close and personal concern that I've seen, where my daughter at one point was on lithium and I think it was nortriptyline, and her psychiatrist was tapering her on the lithium, and at my daughter's request, because she had a friend who did well on it, added Zoloft, and meanwhile she was below the therapeutic level on lithium, and it appears that these having two antidepressants, one being an SSRI, really flipped her into a psychotic mania, and I guess that's what I've observed, and I also have a general question about the whole issue of iatrogenic bipolar. I was a school psychologist for 30 years and saw this increasing trend of first the initiation of the diagnosis of juvenile bipolar, and I'm very concerned that there's a lot of children that end up getting diagnosed with bipolar as a result of being escalated either by a stimulant medication or an SSRI. So I appreciate your thoughts about that.
Sure. So the first thing having to do with two antidepressants added to lithium as lithium is being increased, and at least some sense
it was decreased. It was decreased.
Lithium is being decreased, and some sense of increasing vulnerability and perhaps a cause and effect with the antidepressants causing a manic episode. That's certainly a strong possibility, and in someone who's vulnerable to that, it would be something that I certainly would not endorse, especially if somebody's had mania before. But you bring up such a complicated issue, because a lot of people with bipolar disorder will present first with a depression, and if they've never been manic or hypomanic before, you actually don't know that they have bipolar disorder until they have mania or hypomania. And so what happens, sometimes they're treated for their depression, and then they cycle into mania or hypomania sometime later, and it's actually a little harder to know if it's really cause and effect or would that have happened anyway. So that actually goes also into the concern you have about iatrogenic bipolar disorder, of it somehow being caused by the medications themselves. And by and large, I think that the medications can precipitate mania or hypomania, but probably less so that it actually causes it to happen. It probably doesn't cause it to happen in somebody who doesn't have the propensity to develop bipolar disorder. So again, that's why it's just a little fuzzy about real cause and effect. And you know, there are also two sides to the coin. One side in the coin is that the majority of children who really do have bipolar disorder go untreated. And there's a recent large epidemiological study that shows that. Kathleen Marikangas and Ron Kessler have published on that. So that's one side of the story, is you have these kids who really do have it who aren't treated or aren't treated appropriately. And then you have the other side where it's not entirely clear what's going on, but they get diagnosed with bipolar disorder and it's unclear if they have it or not. And that's still an ongoing controversy in the pediatric psychiatry field. And I don't know what the answer is.
You see, I remain highly skeptical of it, largely because there are no, biomarkers that would even, there's a circularity of reasoning about it that concerns me. And I've seen this happening where a child may get placed on a medication. I'm not saying that it happens blithely or cavalierly. In some cases it might, but in many cases parents is, going through things. But they start, whatever the symptoms are, if it's depression, sometimes things that look like ADHD, and then they begin on a course of medication. Now then, in some cases, symptoms appear that were not there before in terms of mood lability and so forth, and then it's assumed that there was an underlying bipolar. And I don't think that that's scientifically and in terms of practice, I don't think that's a very sound practice, and I just find it hard to believe that there are this escalation of children with a true underlying brain disorder, that I think at least in some cases it would be more appropriate to diagnose the later symptoms as a substance abuse mood disorder and therefore treat it accordingly, because the way that you would treat them is very different. And I think it very much concerns me that many children who should not be labeled with some type of and I'm more concerned about the false positives than I am about the false negatives. I'll put it that way.
Sure. Well, there are two interesting sources of data. One is from Boris Burmeyer from Pittsburgh, who did a large longitudinal study of children who may have bipolar disorder, maybe they don't, but it was something close to it. And he found out if these kids were followed over time, that actually a large proportion of them ended up having bipolar disorder. Not all of them, but a large proportion of them ended up having that. And the other thing has to do with retrospective reports from adults who have bipolar disorder. If you ask them at what age did they first really experience problems with mood, basically 65% of them say that it happened, before the age of 18. So there's some tension between both the false positives and the false negatives, and I hear your concern.
The name of the researcher is Boris. Could you give me the last name again?
Burmeyer.
That's B-E-R-M?
M-H-A-E-R. B-I-R-M-H-A-E-R. He actually won a very nice prize from the Brain and Behavior Research Foundation, and you can see him online with a 2-minute video. It's really very nice.
So he's out of University of Pittsburgh, did you say?
Yeah. Mm-hmm.
Thank you.
This is Jan in Chicago. Can you hear me?
Yeah, go ahead.
Although I have an adult son that fits in this category, I am listening more for the work that I do in the area, and this is a different Jan in Chicago than spoke before, work that we're doing in the area of nursing home overuse of antipsychotics with persons with dementia. And, of course, person-centered is a key buzzword for the work that we do as well. I'm just wondering if there's a place for that population in your Patient-Centered Outcomes Research Institute.
Well, thank you for that. The grants that were given out by PCORI were highly competitive, but they only had 18 of these patient-powered research networks that they funded. Half of the 18, 9 out of the 18 are in rare diseases. And of the other 9 so-called common diseases, again, we got the only one in psychiatry. So that would actually be outside of our purview, unfortunately.
Okay, thank you.
I think there are some AHRQ interest areas in the overprescribing of antipsychotic compounds for people with dementia. As you know, there is a black box warning, for the use of antipsychotics in elderly people with dementia. So that's definitely a big stop sign. And I don't know if there's a quality department or a medical director at your facility that you could chat with about that, because that is something that should be on everybody in a leadership's mind, is that there are known risks to these compounds in that population.
Thanks.
Okay. Another question.
if there aren't any more, this is Peter in California. I'd like to go back to the 6 aspects of wellness. And
sure, go ahead.
Please, I've been reviewing them, and I appreciate each category. However, it seems as if there would be some that would be preconditions to others. For example, I think that self-acceptance would be initially one of those, in that, and we're talking about those children suffering from manic depression, adult children. If they don't accept their condition and understand it for what it is, I can see that a lot of these other things, such as environmental mastery, won't occur, autonomy won't occur. So, do you concur in some respect? And also, which one would you, or several would you suggest are foundational, or the well springs for the others? So, purpose being that I wish we can't address all of these at once with those who are suffering from manic depression. So, is there one or several key elements that you would suggest?
So, based on Carol Riff's work, one of the things that's at least remarkable in the community is that these different aspects of psychological well-being are actually independent of each other, which you wouldn't think would be true. But she's done extensive studies and show that they are independent. They're really not dependent on each other.
I appreciate that, but does one spur the growth of another, even though they're independent? Because I can see they are separate categories. For example, if self-acceptance is the main drive for the others, maybe that would produce all of the positive other 5. But is there that correlation? For example, with our son, I have told him that this had nothing to do with his doing. He is in no way blameful for it. Nevertheless, it's a malady which has occurred, and just like those who have other physical, mental, psychological, organ disabilities that they didn't contribute to, this is something that he has to address.
Sure.
So that was at least my basis for his self-acceptance is this has occurred, and we have to deal with it.
Sure. I think your points are very well taken, and I think for any individual, there may be a different hierarchy of deficits in these 6 aspects of well-being. And perhaps the thing to do is to figure out which one is most prominent, which one is most lacking, and then how do you help that one aspect first?
That's great, and I appreciate that very much. I can see that any one of them may be the springboard for all the others to fall into place.
Yes. And you know, for those of you on the line who are caretakers and have loved ones who have the disorder, it's also something to think about for your own psychological well-being.
This is Sarah from Phoenix, Arizona. I'm sorry, I
have
one question. Sorry. Thank you for joining the call today. My question is more along the lines of what we were just talking about for the family or caretakers, so not so much the medical treatment of bipolar disorder. So what can we as caretakers do to help those with bipolar disorder the best? Is it best for us to focus on supporting them in finding and fostering the aspects of psychological well-being that you mentioned? Sometimes I anyway, feel as though I'm doing more harm than good. So what do you suggest? Where is our help most helpful?
So I think part of the challenge of loving somebody who has the disorder and living with them is trying to be extraordinarily mindful and careful about how you react to them. And that one of the things that we know from research is that if they're doing things that are irritating and annoying, And if other people react to that, where it gets hotter and more difficult, it tends to make things worse. So
right.
it's part of the heart of family focus therapy to, in effect, try to respond. Almost, you take a breath before responding to anything that's happening, to figure out, okay, how can you respond that may not make things worse, and how may you respond that might make things better? And that's extraordinarily difficult to do.
Right.
There's some people who've published on this and some good books available for this. There's David Miklowitz's The Bipolar Disorder Survival Guide. I don't know if you've seen anything like that. But that's the sort of thing that can give you some guidance of, how are you supposed to respond to this? What is it that you do? And it's not easy.
Thank you for your help.
Sure.
So I had a question for you, Dr. Nierenberg. This is Ken. How can NAMI's membership help you with this project?
Well, I think because this is a true collaboration, because this is unprecedented in both size, scope, and depth of really the patient, collaborator, citizen, scientist involvement in all aspects of this. I think one of the ways that we can work together is, first of all, getting the word out, of trying to really have the story of why would anybody do this? How is this in someone's best interest? How is this going to drive the field forward in ways that we never could before? And how do we do this with this novel partnership? Because Ken, I don't know if you've ever heard of anything like this before with this depth. So I think the ways it can be helpful is through getting the word out. We'll probably work with NAMI to get a link to how people would sign up for this sort of thing, which we anticipate will happen in about 5 or 6 months when we finally build the infrastructure for this. And being able to continuously talk about, how do we make this all better together? What is it we need to do together to have better outcomes for bipolar disorder and for depression?
Excellent. Well, I'll look forward to this collaboration, as we go forward. It is new ground.
Yeah, I agree.
Other questions for Dr. Nierenberg? We're coming to the end of our time. I wanted to make sure Dr. Nierenberg had a chance to get out his favorite books, resources, websites, and other things that will be helpful for our listeners.
So I think NAMI is essential, and if you're all on this call, you're connected to them. Depression and Bipolar Support Alliance, the International Bipolar Foundation, all extraordinarily helpful and trying to give people community, which, by the way, is the other thing that we want to do with the project that I talked about earlier, is to give people a new community to support each other. You can also look at things like Patients Like Me and see what's being reported on there by people about how they're doing and what their experience is with certain medications and other treatments. I'll mention again David Miklowitz's book, The Bipolar Disorder Survival Guide. There's another one by Michael Bauer that I think came out more recently that some people are finding helpful. My colleagues here just published the Bipolar II Disorder Workbook. That's by Stephanie McMurrick-Roberts, Louisa Sylvia, and Noreen Riley-Harrington. That's the Bipolar II Disorder Workbook. I think these are the sort of resources that people might find helpful. If we all work together, I think we can do just extraordinary things to move the field forward.
Well, great. Well, we look forward to participating with you. We look forward to learning with you. And, I'll collaborate with you offline to figure out, how we can touch base with you in our newsletter or on our website or other ways that we can make sure that our membership, which is strong, engaged, and as you can see, very good questions, can work with this project. So what I'd like to ask everybody to do is sing off of mute, hit #6, and just shout out a thank you to Dr. Andy Nierenberg, who donated another hour of his time to our membership and to our own continued learning.
Thank
yes,
you.
Thank you very much.
Thank you very much.
Thank you, Dr. Nierenberg. We hope to have you back in the future as we collaborate together on this project.
Great. Thanks so much.
Thanks, everyone. Take care. Talk to you next month.
Bye-bye. Okay.